Professor.
Ladies and gentlemen, it gives me great pleasure to welcome all of you in webinar number 24 among the series of webinars organized by the Egyptian Society of Neurological Surgeons and the Continental Association of African Neurosurgical Societies. I would like to express my sincere appreciation to our distinguished speakers, Professor Tariq Khan. He is Dean and Chairman of Neurosurgery at Northwest School of Medicine in Pakistan. He is Dean of Neurosurgery, College of Physicians and Surgeons at Peshawar in Pakistan. And he is the Chairman of the Neurotraumatology Committee of the World Federation of Neurosurgical Societies. Professor Abdul Hafiz Shihab al-Din. He is a professor and chairman of neurosurgery at El-Sahel Teaching Hospital, Ministry of Health in Egypt. He is the former president of the Middle East Spine Society, and he is the current treasurer of the Egyptian Society of Neurological Surgeons. Let me welcome Professor Ahmed El-Fiqi, professor of neurosurgery, and he is co-chairman of the neurotraumatology unit at Cairo University. Thanks to all of you for contributing to this neurosurgical activity and for giving us much of your time, sharing your knowledge and experience with young neurosurgeons, especially at this difficult time of COVID-19 pandemic is well appreciated. I will be honored to be the moderator of this session with my colleague, Professor Omar Youssef, Professor of Neurosurgery at Ain Shams University. Thanks to all of you. Omar?
Yes, good morning and good afternoon for all everybody. I'd like to introduce our colleague, Professor Abdul Hafiz Shihab al-Din, to present his topic about the anterolateral approach for thoracolumbar fractures. Yes, welcome, Dr. Abdul Hafiz.
Thanks, Professor Omar. Thanks, Professor Nasser. Welcome, Professor Khan. Actually, it's a great pleasure for me to be together as usual. I would like to talk today about this topic, which is anterolateral approach to thoracolumbar fractures. We all know that the spinal column injuries constitutes about 3% of all trauma cases. And the concomitant spinal cord injuries is around 10% of them. And this type of trauma occurs mainly in youngs. And the thoracolumbar segments of the column receive about 3/4 of all the spinal injuries. And actually, the field of spine is growing in the last decades through better understanding of the spinal biomechanics and bone growth physiology. And there is a great technology advancements either in the diagnostic imaging or through the development of new spinal instrumentations and tools. In addition to that, the surgical concept itself is highly progressing. And if we look to the anatomy and the biomechanics at that regions, you can find that the thoracic spine is fixed by the rigid rib cage articulations, and the specific features of the facet joints are coronally oriented, compared with the lumbar spine, which is mobile, and its facet joints is oriented sagittally. And in the thoracolumbar regions, the facets are oblique. So this region is transitional zones between the thoracic kyphosis and the lumbar lordosis, and where the rigid thoracic cage joins the mobile lumbar spine. And adding to that, the cross-sectional area, which represents canal cord ratio, is relatively narrow. And all these features will give it's a spectacular data for these regions. And the assessment always, as usual for any trauma cases, starts with airway, breathing, circulations, and immobilizations. In addition to obtaining a good history, which represents the mechanism of trauma, and examinations as a whole, and the imaging of the spine using X-rays, CT scan, and MRI, and so. And always we need to have a classification system for any type of injuries. And the ideal classification system will convey informations and define the treatment plan and monitor the patient progress. In addition to that, it can be used as a research tool. This is the ideal one. And if we look to the clinical evaluation of our patients, we have ASHI score, where A represents a complete injury, including sensory and motor, and E is a normal motor and sensory functions of the patient. And in between, we have B, C, D, which represents a various degree of affection of the neurology. And for functionality, you have Dennis pain and work scale, where pain can be no pain. If there is no pain, you give the one score of one. If you have severe pain and
دكتور عبد الحفيظ please.
Yes.
the side is fixed, not turning on. ما بتتغيرش، السايد ثابته ما اتغيرتش.
انا عندي بتتغير، يبقى
لا.
هوقف الشير وهشير تاني.
انا افتكرت انك انت اللي قاصد.
لا.
Okay, Dennis pain and work scale.
Okay.
Okay.
Now it's changing.
Dennis pain and fracture classification now.
Yes. And now we are talking about always we like to monitor pain in addition to the clinical, motor, and sensory, and we like to monitor also. We must have a functional scale. So we have Dennis pain and work scale, and this represents also if the patient returned to heavy work, you have a score of 1. And if the patient is unable to work at all, you have a scale of 5. And if we look to the classification of the fractures itself, and this, you have Dennis classifications, where he classifies the injuries to minor injuries for that trauma inducing fractures of the transverse process of the bars interarticularis and for the spinous processes, and for major injuries. And we can see here we have compression fractures with affection of the anterior column mainly. You have burst fracture with compression fractures of the anterior and the middle column, and we have seatbelt type of fractures with it is a distraction injury affecting the posterior and the middle column. And we have fracture dislocations with affection of the 3 columns of the spine, as we can see in this diagram. But for TELEC classifications, which are the good classifications and include the morphology of injury, the integrity of the posterior ligamentous complex, and the neurological states of the patients. For injury morphology, you give 1 point for compression fracture, you give 1 point for burst fracture, you give 3 points for translation and rotation, and 4 points for distraction. And for posterior ligamentous complex, if it's intact, you give 0. If it is disrupted, you give 3. And for the neurological states, if intact, you give 0. And if incomplete, you give 3. And actually, this TELEC classification is very beneficial, because if the patient have 3 points or less, this will be treated non-operatively, conservatively. And if the patient have 5 points or more, this patient require surgical intervention. And for 4 points, this is in the gray zone. You can treat him treat the patient either conservatively or you may choose surgery. In addition, it determines the surgical approach itself. If you have an anterior compression radiologically and the incomplete neurological deficit, then the best for the patient is to go anteriorly. But if there is incompetent posterior ligamentous complex, you will go posteriorly. And sometimes, in few cases, you need to go anteriorly and posteriorly if you have a neurological deficit and anterior compression in addition to incompetent posterior ligamentous complex. And another classification, which is AO, alphanumeric system, it is a very detailed, compressed classification, and you can go for the literature and see it. For radiological evaluation, please look for the anterior vertebral height compared with the posterior one. It's important to look to that because, as I will mention, it can determine if the patient is surgical or not surgical. And also, you have to look to the canal compromise by retropulsed bone fragment. And you can measure the anteroposterior diameter of the canal and say this canal is compressed 60% or 50 or more. Or you have a computer program where the number of pixels is measured, and through it you can say this is the canal volume is reduced by 50 or 30 or 70%. In addition to that, you have to look for the X-rays, and you can get the cup angle and the local kyphotic angle of the fracture vertebrae. Addition to that, you have to look also for the radiographic criteria for instability, which is defined if you have a loss of anterior vertebral height, 50% or more, or retropulsed bony fragment and the canal compromised more than 40%, or kyphotic angle of 20 degrees, or if you have multiple adjacent compression fractures. Actually, Benzel scoring system for instability also is beneficial, as it is also you have these numbers and you have to calculate it and see if your patient is stable or unstable. And if you get the patient to 2 to 4 points, it's limited instability. 5 or more points, it's profound instability that should be considered, and you have to fix the patients. And always the aim of treatment is to prevent neurological deterioration, minimize and to eliminate the spinal deformity, and to ensure adequate fracture healing, and to avoid sequences and the complications related to that injury, and ensure also adequate functional recovery. You have many options. You can go conservative through bed rest, racing, and others. And through this time, you can do a peaceful watching clinically and radiologically for your patients, or you may do surgery. And this surgery, you can do it either open or minimally invasive. You can go posterior, you can go anterior, you can go combined. And still controversy exists about the best to be done. But the selection of the approach is usually depends on the location and the extent of the bony and the ligamentous injury, the neurological deficit of the patient, the percentage of canal compromise, and the presence of deformity and the pain status. And the ideal approach is that one who give me an optimal exposure, which is extensile, and it should be anatomically based and appropriate to the pathology. And it should be safe with low morbidity. And if better, of course, that does not exist, it may be fast and simple. And I have to consider the surgical skills needed to do that approach, familiarity of the surgeon with that approach, and the available tools and the facilities in your country, in addition to the costs. But the surgical philosophy includes two things: stabilization through inducing a good fusion, and fixation through instrumentation, plus or minus neural decompression. Always you need to do that. But you have to consider that long-term stability depends on fusion. So the rule of instrumentation is to maintain the stability till fusion matures and become quite apparent to you. The posterior approach is attractive because of the surgeon familiarity of all the spine surgeons or all neurosurgeons is with that approach. It is really beneficial for embedded laminar fractures, and if there is intraspinal hematomas or posterior ligamentous disruption, and with multiple level involvement, and to augment the few cases of anterior fusion. It needs sometimes, if you have PLC injury also, you need to do it. And if we look, the length of the fixation that you need, sometimes the ideal is to do 2 levels above the fracture site and the 2 levels below. But you have also an option to put 2 above and 1 below. Or you may do 2 above and 1 below the fracture site and 1 index screw in the fractured vertebrae. Or sometimes you may do 1 above, only short fixation, 1 above and 1 level below. And if you add an index screw in the fractured level, this will enhance greatly the biomechanics of fixation by about 20%. But this index screw, there is a problem of if you have a fracture of the pedicle, and if you have a fractured body where you may push, if you put an index screw in a case like that, you may push these bone fragments towards and you may induce vascular injury in front of the colon. But what about the reduction measures of the retropulsed bone fragments? If you go posteriorly and you have an intact posterior longitudinal ligament and the annulus, and this surgery is performed early, then you can do only partial reduction of the retropulsed fragment through ligamentotaxis. By correction of the kyphosis and distraction, the bone fragment will be replaced posteriorly. But these maneuvers can also, you can add to that, you can go interlaminar also, and any loose fragments inside the canal, you can remove it during your surgery. Or you can you do transpedicular decompression of the body. As we can see in this diagram, you remove bone from here, from the body, through the pedicle, and you can also make a reposition and pushing back of the retropulsed fragments. But this maneuvers also does not totally decompress the neural canal, and the neurological recovery is incomplete. And what about you destruct an intact? If the posterior elements is intact, you are destroying it. And also, in addition, you are fixing 4 motion segments. And that's why the anterior approach to the canal is important. And because also most traumatic spinal lesions affect the vertebral bodies, and this represents 2 columns of the 3 columns and that stabilize the canal, and it carries about 80% of the body weight. And that's why the reconstruction of the body and anteriorly is extremely important. And the anterior approach is getting popularity through awareness of the approach and the progress in the surgical and the anesthetic technique and the expansions of the indications and the availability of newly designed instrumentation, as we will see. And by assessing the canal, the spinal canal anteriorly, there is a great exposure of the anterior column and the adequate decompression of the spinal canal and the foramina with concomitant placement of interbody devices, plating, and effective distraction and the deformity correction, and ensuring increase the rate of arthrodesis as the graft is under decompression. And almost in addition to that, you are avoiding back muscle dissection and the trauma, and you don't disrupt the lamina or soft tissue posteriorly, which is tension bands, and you avoid also manipulation and scarring if of the posterior tissues if exists. With a complete clearance of the spinal canal is really mandatory, especially if have a neurological deficit, and this is only possible through the anterior roof. That's why you are ensuring and you get effective neurological and functional recovery. In addition, you can do concomitant instrumentation. As any approach, you have a complications either during surgery or post-operatively. Either of the spinal cord or nerve roots, you may induce vascular injury, visceral injury of the diaphragm or of the lung itself. You may get cardiac arrhythmias. Post-operatively, you may get pneumothorax, and hemothorax. You may get infection. You may hardware and fixation related complications, pneumonia, atelectasis, intercostal neuralgia, or concomitant spinal instability if fusion fails. And I am going now to go to the steps. That's how I am doing in this mini thoracotomy approach for thoracolumbar fractures. I take my patients with using single lung anesthesia. The patient in the left lateral decubitus position, and the arm is abducted, as we can see. And always you have to do flexion of the operative table about 30 degrees to open the desired spaces. And you have to know also the relevant anatomy is very important. So you have to study well how to do this operation and the nearby structures. And we go from the left side to avoid the liver and the inferior vena cava, because when you put your instrumentation adjacent to aorta is better than adjacent to the inferior vena cava. And the opening and the skin opening and exposure is you choose the rib interspace 2 levels above the site of corpectomy. And you start it from the posterior axillary line, the costal margin, and following opening of the skin and the intercostal space, you can see you will have no rib resection is done. I go in between the ribs, and after opening the parietal pleura, you will see the lung and the diaphragm as we can see here. And after opening the diaphragm, it's about 12 centimeter opening. You open now, you are now in the chest, and you are now in the retroperitoneal space in the abdomen. And following that, you open that parietal pleura and you expose hills and the valleys of the spine itself. This is the discs and this is the bodies. Retroperitoneal dissection is done, and segmental vessels ligations is to be sacrificed, and to identify the neural foramina from one side to the other side, from one above to one below. And you start by doing discectomy, one above the desired fracture of the vertebrae and one below, as we see here. This is followed by corpectomy. And always I start my corpectomy in the middle third of the vertebral body. And after that, and you start towards the spinal cord, and you start to decompress the right side first. And always, as I can see, as you see in this diagram, I left the anterior part of the body, and the right side of the body, it's a vascularized graft, and I will put my cage or a graft here, as I will show later. This is after corpectomy. I visualize the dura fully and the cord is bulging inside my corpectomy site. But always I preserve a shell of bone over the dura and over the cord after till the full decompression, because to avoid bulging of the spinal cord inside my corpectomy site. And this, I have to prepare the body above and the body below to receive my plate. And I start by putting this bolt down below the level and this bald above the level, and I insert here either a tricortical bone graft taken from the iliac crest, and if I did that, I have to lift a clear space behind it between the graft or the cage or the cord itself as a safety margin to avoid any complication or recompression of the cord. So as we can see in this diagram, this is my corbectomy in the sagittal plane, and this is my spacer, and I have to lift this clear space between me and the cord. As we will see, you may use a cage like that, filled with the bones that you gain it through corbectomy, and you fill the cage with it, and you insert it, as we can see here. In the corbectomy site, again, you have to lift a clear space between you and the dura. Of course, I put a distractor here over the bolts to allow me to nicely fashion my spacer. And again, here is the blade after its insertion over the cage. The correction of deformity is to be done through distraction over the bolts, correction of the operative table flexion, and the posterior pressure applied to the spine, and through the insertion of the cage or tricortical graft. This helps me to correct the kyphotic deformity. And again, you have to correct all operative table tilts before final tightening of the system to get the best sagittal and the coronal orientation. This is, again, this is the plate in its site after its insertion. And this is the closure of the parietal pleura and the diaphragm. And here is after everything, and you release the lung, and it starts to inflate and close the space. Here is after opening, after closing of the diaphragm, and after that, and here is the skin opening. It's about 12 centimeter length of skin opening without rib resection. By that way, you can do mini thoracotomy and you can do the whole surgery that's needed. Of course, when I was starting this operation more than 20 years ago, I was using a better exposure than that, but gradually, and the size of my opening is decreasing by omitting what is the exposures that I don't need. You have always, you know, your approach should be tested against the time. And against the time, you have to look to the late follow-up, look to the bone fusion with your graft, with the body above and below, and the new bone formation in around the tricortical bone, the spacer, either a cage or tricortical graft. And you have to look for the recontouring of the bony canal. And what about the maintenance of restoration of the vertebral alignment and the clear bone that it's newly formed? I will show all that in my next slides. That's the case with lumbar fracture L1 with retropulsed fragment and canal, where you can see canal compression. And here is the amount of canal compromise is more than 70% in that cases. And here is my early post-operative case. You can see here that the tricortical bone is nicely placed. And you have to see, you can see that the canal is very well decompressed, and there is a clear space between the graft, the spacer that I put, and the canal itself. Of course, this is the plate that has been placed laterally in the left side. And look here, 8 years later, post-operatively, you can see that the graft is very nicely integrated with the body, with new bone formation, all the area surround it, and going towards the cord, you can see also how the body fashion itself, and the canal is restored like as if it is the normal dimension of the canal. Also the same, here is the graft here, this is the new bone formation, and here it is the regained normal canal. And in addition to that, that's another case of D12 fracture, and you can see the amount of of bone compromise. It's more than 80%. I cannot reduce this amount of bone posteriorly. But if you look here for the post-operative, that is the MRI in the sagittal plane here, you can see that the canal is beautifully decompressed, vertebral height is maintained, fusion with the body above, as we can see in this plane X-ray, fusion with the body above and below is established and maintained for many years. And here again, that is the graft that is which is nicely fused with the residual of the body, and there is new bone formation, and here is new bone formation, but the canal is maintained by Wolff's law, and that's what we can see also in the sagittal MRI. That is the best to be done. And here is 3D CT, and you can see the amount bone formation, maintenance of vertebral height, and the canal also, the new bone formation, and around the canal, the same can be maintained. And this is one case with a cage. If we look to the bone around, if we look to this one, this cut, the bone around, inside the cage, and around it, and in front of the cage, and how the canal is regained and reformed with the normal dimension, this means this is a successful technique. The same as I show here as before. But despite these advantages, there are unique disadvantages of the procedure, like the learning curve. Because this is the unusual anatomy, you may need other one to do, although I don't do that. I do all surgery, and my residents can do it all the time. You need a dedicated surgical tool and a good instrumentation devices to perform this surgery. And then one study by McDonald, he found 11% major complications and 24% minor complications, including injuries to the abdominal viscera, great vessels, ureters, abdominal wall, and the neural elements. I am putting this slide to say that there is no surgeries without risk of injuries. But in multi-center study with includes more than 1,000 patients, the neurological recovery was better with the anterior approach, and anterior approach was more effective in bladder functions, improvements, and with fusion only of 2 motion segments instead of 4 if you go posteriorly. And I think that time is running. It is a comparison between anterolateral approach and posterior approach in the management of thoracolumbar burst fracture. This paper was published in 2006. Both of them have been associated with favorable results as well as complications. But angulation correction is better maintained in the anterior group, and the removal of retropulsed bone fragment from the canal is better with the anterior group. A lot of references that I will pass, but this is a very important issue, which is implant failure on the long term. Again, if you would like to test the approach, test it on the long term. Don't test it in the first weeks or first few months. So breakage, bending, or loosening of the devices, and the critical period for this to occur is to be in the first 6 months. And if you look to systems, failure of the device is taken up to 50%, but for the anterior system is about 4 to 11. So it is far less. I will finish that. I will go quickly. I like here to compare mini thoracotomy approach with minimally invasive. If I am doing this surgery also through the thoracoscope. But for mini thoracotomy, I am using about 12 centimeter incision with no rib resection. But if I am using the thoracoscope, I need a working space which with rib resection for about 5 centimeter thoracoscope, it needs 2.5 centimeter insufflation, and working channel, it's about 4 centimeter. So if you compare, if it is the skin incision, it is almost mini thoracotomy is almost identical for invasiveness with thoracoscopy. So it's equal for them. That's why I prefer mini thoracotomy actually nowadays. To conclude, anterolateral mini thoracotomy is demonstrated to be safe and effective. All the goals of surgery, decompression, grafting, restoration of vertebral alignment, and the concomitant fixation can be achieved. And the complications in my cases is which now more than 800 cases through about 30 years are acceptable and reasonable. But it is not a simple approach. You need single lung anesthesia, hypotensive. You need perioperative monitoring. You need early operation before callus formation. This makes the operation more easy, and the better understanding of the unnecessary exposures by time if you are gaining experiences. So you omit, you cancel initial abdominal and the peritoneal dissection, rib resection, and the large circumferential cut of the diaphragm. And you need modern surgical techniques again, ICU and rehabilitation, surgeon familiarity with the approach. And by assessing the spine anteriorly, there is greater exposure of the anterior column, less muscular retraction and less blood loss, reduce the operative time, greater distraction, in addition to many advantages. And thank you for your attention.
Thank you, Dr. Abdul Hafiz, for this nice, interesting presentation and interesting work. We may open discussion for 5 minutes only. There is here two people raising hands.
And can I please? Can I?
Yes, Professor Osama Ghannam. Yes, please.
Hello, everybody. Good to hear you, Professor Abdul Hafiz. I haven't seen you a long time. I've seen you now with a good look and a good smile of you. Nice teeth as well. What is really my comment is the prognosis of the spinal cord injury has nothing to do with the way of the approach. I mean, your trajectory, whether from front or lateral or posterior, it's always nothing to do with the function. You did a very good anatomical work, correction of the anatomy, mechanical, but nothing to do with the function. If the patient is going to recover, it will recover whatever is needed. But we know, very important fact, that cord injuries in this dorsal region, they are very bad, whatever you do from front or back. Cord injuries in the lumbar region, they are very good, especially if you do minimal manipulations. That's why I'm just want to say that the functional recovery depends on the location of the lesion or the location of the injury. Thank you very much.
There is
Abdul Hafiz, do you want to make any comment about Professor Osama?
Yes. Hello, Dr. Osama. It's nice to see you too. Actually, always I am happy to meet you. As regards to, if we have always as a neurosurgeons, we look to the side of the lesion. If the pathology is anteriorly, you go anteriorly. If the pathology is posteriorly, you go posteriorly. If the pathology is laterally, you go posteriorly. You go laterally. So always this is how our scenarios are going in all aspects of neurosurgery. And if we look to the cervical discs, for example, okay, everybody was doing it 40 years ago or so, posterior laminectomy. But nowadays, I think we go anteriorly if the pathology is anterior. And we are talking about a cord or conus and not a nerve roots. So selection of the cases for the approach, I think it depends on the amount of compression, as I mentioned. There is techniques, as I mentioned also, and as I show in the beginning of my lecture, to go posteriorly and perform the job partially. You can do your job partially only posteriorly, but this can work in many cases. But in some cases, I have to go anterior.
Okay, there is a question from Dr. Nabil Ali. Dr. Nabil, please unmute yourself. Dr. Nabil, please unmute yourself. Dr. Tamer Saadani, please unmute yourself. Dr. Tamer Saadani.
Amar, I just want to ask Professor
Okay.
Abdul Hafiz
Dr.
just
Nasser.
a very simple question. Now we are teaching young neurosurgeons, and I would like to know your experience. I have seen a diagram in your talk about the length of fixation concerning posterior approach. How many screws do you like to put above and below, and on which factors it depends? That's the first question. And the second question about the anterolateral approach. What's your advice? When to use this approach and when to use the posterior approach? Because as far as you showed us now, it is a big and major and extensive approach. Thank you.
Thanks, Dr. Nasser, for your two questions. As regards to the posteriorly, how many screws to be put? There is a very big debate between long fixations, two levels above and two levels below, and short fixation with one level above and one level below. And always as a neurosurgeons, we fashion your surgery according to the available data of the patients. So it means the amount of destruction of the segment, it defines. I can do, of course, the best to be done is to do short segment, one above and one below, and one screw, index screw in the fracture level. So you eliminate two motion segments. And this is, but not all the cases. If you do it, maybe if the injury is somewhat moderate, it may work. But if the injury is extensive, it may not work. You will end by fraction of the screws or the rod itself. And you have to go again and put two segments or more in above and two segments or more below. So you have to analyze each case, like the kyphotic amount. That's why I put the radiological evaluation at the beginning of my lecture. To what about the cup angle? What about the kyphotic deformity? What about the duration saying fracture? It's somewhat fresh fracture or an old one. So all these factors should be put into consideration. But classically, I know I put a lot of slides about comparison papers, published papers comparing all that, but because of time and I go through it so quickly, although it carry a lot of nice informations, but there is no time for it. But this is why I fashion it. As regards to the second question about the complexity of the approach and the difficulty and associated complications, I can say to you, of course, maybe in our center, it's an exception because actually we are doing this approach since 1991 or 1992. And actually, why I at that time I go anteriorly? Because I have a failed posterior cases يعني اللي رماك على المر لا مر منه. I'm pushed to go anteriorly because I have a failed posterior cases and I need anterior spacer is extremely important. Even if you go posteriorly, that's another message that I like to say to youngs. Anterior spacer is extremely important to expand the anterior and the middle column, even if you go posteriorly. So, but I don't think nowadays, with adequate training of your residents, and I think I have many of them can do this big part of this work or all the work alone without any other speciality to help them.
And so as far as I understand from your discussion, Professor Abdel Hafiz, that
Just one comment, Dr. Nasser.
Yes, you are not using the posterior approach anymore?
No, no.
What is when are you using the posterior approach? When and you are using the
yes
anterolateral approach? And what about young neurosurgeons? I think it needs a good learning curve. Your
yes.
center is an exception, maybe.
Yes, when there is, I am using. If you ask me, you can ask the question by another way. What is the percentage of cases of thoracolumbar fractures that you are using the posterior approach? What is the percentage?
No, the indications, the absolute indications of anterior approach and posterior approach.
Posterior colon failure with retropulsed fragment less than 50% or 50%. I am going posteriorly.
Okay.
Because
I think there's
you can clear the bone from the canal. You can clear. Definitely, I have to clear the bone from the canal. You can rely on the posterior approach to clear the bone from the canal if there is a canal compromise up to 50% of the canal. But if you have 80% or 90% canal compromise, you cannot clear it through the posterior approach unless you go transpedicular decompression, as I show in the slides. But anteriorly, it is very nicely will be done.
The most important thing, Dr. Abdel Hafiz and Dr. Nasser, in choosing the between posterior and anterolateral is two items. The first item is as Dr. Abdel Hafiz said, the size of the retropulsed segment. If it's more than 70%, it should be go to anterolateral. The second item is the body height. The wedging more than 70 or 80%, it will make a deformity. And this will disturb the anterior and the middle column. When you put, that's why your posterior cases failed. That's why you put a tension band posteriorly without correcting the middle and the anterior columns. That's why it will fail. That's why. Yes. That's why if you have more than 70% retropulsed or 70% body height, you have to go anterolateral to support the middle and the anterior column to avoid any tension, posterior tension band. It's very. And the second comment about the mini thoracotomy, it's a very nice, and I used some cases personally for thoracoscope and others mini thoracotomy. It's quite nice, and it could solve the problems except in dorsolumbar fractures or higher fractures, as is you have to interfere with the diaphragm's attachment. This is the only obstacle.
No, Dr. Omar, all my cases is thoracolumbar, and I open the diaphragm through mini thoracotomy. All the cases that I show is thoracolumbar.
That's good. That's nice. Nice.
No. So many thoracotomy. I can say I can.
You could deal with the diaphragmatic attachment.
Yes,
very safely, very easily.
I open the diaphragm. I show that in the slides. I open the diaphragm and I close it through mini thoracotomy. And
that's very nice. Very nice.
It is possible. It needs. What's the difficulties actually?
Learning curve. It's a learning curve.
Learning curve. Actually, it needs a good learning curve and a good tools. You need a very good surgical tools, drills, and everything, and the plates and the screws and everything, and the retractors and the anesthesia. You must have a system. You must have a system to do this kind of operations.
Okay, thank you very much for this very nice experience, Dr. Abdel Hafiz. For the sake of the time, may we shift to the second speaker, Professor Dr. Ahmed Al-Fiki, about the topic about decompression craniotomy, challenges and tricks for better outcome in developing countries. Yes, welcome, Dr. Ahmed.
Yes, thank you, Chairman. I'd like first to thank Professor Dr. Nasser El-Ghandour for giving me the chance to share my experience in this fruitful meeting. We will talk about decompression craniotomy because it is an important goal to have a decompression in cases of traumatic brain injury, especially in developing countries. First, I would like to introduce my institute. So I belong to Qasr al-Ain, which is the first medical school in the Middle East from 1827, which lie in an island inside the Nile River, downtown Cairo, with more than 2,700 staff members and more than 9,000 undergraduate students and more than
Dr. Ahmed,
3,000.
Dr. Ahmed, please, could you magnify your slide?
It is not moving.
لا, magnify it. Please magnify it. كبرها يعني كبرها من ال
Yes.
من slide.
Make it a full screen.
Yes, it is like this one.
Yes, perfect.
This
perfect.
is okay?
Perfect.
And in Qasr al-Ain, we have more than 4,200 beds in all the specialties. And our neurosurgery department includes 160 beds for adults and pediatric cases with 7 operating rooms. 2 from them are dedicated for pediatric cases. We have more than 20 ICU beds. 12 of them belong to neurotrauma. We have more than 55 beds for neurotrauma and emergency cases. We operate every year more than 3,500 operations, more than 1,500 for neurotrauma and emergency. And the neuroemergency department admit patients nearly 2,400 per year. And when we talk about traumatic brain injury, we know that's still major a universal health problem with nearly the same epidemiology in the last 3 decades. The increasing incidence of death for handicapped people is mentioned in the World Health Organization report, and it is expected to be a major cause of mortality and disability. These are some numbers for traumatic brain injury. More than 2.8 million persons have traumatic brain injury every year, with mortality rate over the year more than 53,000 patients, with daily deaths more than 150 cases. And there are 3 million to 5 million American people who live with head injury, disability-related problems. And the lifetime cost per case for severe head injury equals 400,000 euros. Of course, we may have unlucky situations in developing countries because we don't choose where to be born or to live. So we may have the luxury to have like a transportation air ambulance or a small like the below picture, which is a small ambulance. So, but other problems that may help us to understand the outcome for traumatic brain injury is underserved large areas. For example, in Egypt, we have more than 100 million population, but we lack of underserved areas for neurosurgery services. We have places in Egypt that if you have a head injury, you have to travel for more than 4 hours to have an hospital with equipped neurosurgery service. So there is a problem of coverage, the service all over the country. Moreover, there are some countries in Africa lacking the required number of neurosurgeons. Some countries may have 2 or 3 neurosurgeons. For example, Kenya, with more than 33 million population, have less than 50 neurosurgeons. And this will be reflected on the time from trauma to skin incision, which is very important to have a good outcome. And not only the time which take the priority in having a good outcome, but also the care during this transportation. So the trained personnel who accompany the person with head injury is very important because he may save his life by doing him intubation and hyperventilation during the transportation. And the severity of injury depends on the impact of the force, which if the force is mainly directed to the skull and the scalp, it will result in skull fractures. including compound depressed fractures and basal fractures. But if the force of trauma is directed mainly to the soft tissue, which is the brain, dura, and the arachnoid layer, we will have tearing for the bridging veins, resulting in subdural hematoma. We may have also contused brain and intracerebral hematomas. So it depends on the impact and force of impact, which part of the skull is applied on. And of course, if we have a subdural hematoma contused the brain will swell later on. And this will be reflected on the mass effect of this hematoma, causing, as we know, deterioration clinically, and we will have one or more of herniation syndromes, which may compress the brainstem to cause deterioration of the vital signs and eventually arrest. Of course, this compression for a long time will lead to brain hypoxia, and later on, the patient may suffer from permanent ischemia. So as we know, time equals pain. So we have to do as early as we can from the diagnosis to decompress the compressed brain. We have many types of brain decompression. Of course, the medical decompression by the dehydration fluids like mannitol or hypertonic saline is important if the blood pressure is allowing that. Of course, surgical decompression by craniotomy or hematoma evacuation, or more recently, I'll call it internal decompression by cisternostomy. So the rationale to have a decompression is to evacuate the hematoma, to remove the compression, and the other rationale is to gain more room for expected angry brain, because it will swell later on after you evacuate the hematoma. The contused brain will swell more, so you have to give him a room to have the time to dehydrate the brain later on and regain its normal position again. And this will have us think about the balance between the decompression craniotomy, because we don't want to see these images post-operative. And it is all related to undersized craniotomy. We may have some contused brain around the edges of the craniotomy. We may have a new appearance of new hematomas, which was compressed from the subdural hematoma, and when we decompress, we have, like this one, we have a newly developed hematoma. Or of course, we don't want to have this brain out, like the mushrooming effect due to undersize of this craniotomy. So the size matters about the craniotomy that we have to do. And actually, when we have a large craniotomy, it will help to decompress and give the brain the chance with equal distribution of the force, not to bulge through the craniotomy. And in our study, we assigned, or this is the classic actually, to have a constant size for these per holes. One of them is the mid-temporal basal above the petrous bone, and one is 5 to 7 centimeters behind, and one at the parietal eminence like here. And we do 3 parasagittal burr holes, 1.5 centimeters from the midline. Then we have a supraorbital burr hole and the key burr hole. And this is actually the best size for decompression for the brain, because it will give us a craniotomy with 13 to 15 centimeters, which is enough to do craniotomy for most of the hemisphere. Of course, when we do the classic hemicraniectomy, we have to store the bone. And the most common site is the abdominal pocket. And of course, if we have the luxury to have a bone bank, we can store it in the bone bank. And some surgeons prefer to do it, to put it like this one on other side of the scalp in another place. But if you have to do it like this, we may have some infection that may happen, and we can have an abscess, and we can lose this bone later on. And sometimes if we re-put the bone again, it may be resorbed. In other situations, it may be hyperostotic and shrink in size and grow, because if the bone is put in the abdominal pocket, it will grow, but it will grow in the thickness, not preserving the normal dimensions in the prior harvesting. So it will be more thick and smaller in size. So all these situations allowed us to think how to preserve the bone in the first surgery and avoid to remove it totally. And this make Professor Lepchurian think about the cisternostomy, because his theory is built up on the CSF pressure, and he can use this pressure in the CSF to drain it outside, and this will allow the brain to not to swell and allowing the bone to put it back again, because his theory is built up on when the head injury happened, the brain will swell, and the CSF in the ventricle and subarachnoid spaces will go through the Virchow's spaces inside the brain itself. And this is what makes the CT with small ventricular size, where the CSF then, it is inside the brain. And his theory is to do extradural bony work in the skull base level to reach the clinoid. Then he opens the dura from outside to reach the cisterns and open the cisterns together. And this will lead to withdraw the CSF from the Virchow's spaces to the CSF cisterns. And this will decrease the intracranial pressure, preventing this from happening. But as we know that this will need a long learning curve, because to have experience to do the drilling of the clinoid and skull base, it will take a long time. And to speak practically, this will not be the situation when a patient with a subdural hematoma will come after the middle of night to have an experienced neurosurgeon to do this procedure. Although it matters and it have a good rationale, but it will take a long time. And this allowed us to think about the hinged craniotomy, which is leaving the bone in place after adequate decompression. And there are many techniques to fix this bone. We can open the bone like this from inside and putting it flail, or we can fix it with many plates like this one, leaving the decompressed part. This is higher than this one, but actually this will need another surgery to reposition the bone again. And you can fix it with Vicryl or nylon with a spacing, and later you can push this to reposition the bone. But we published a technique that may be helpful in avoiding bone flap replacement second surgery. And this technique, we were inspired by the forensic doctors when they explain how the bullets enter to the skull and go outside. When she goes outside, she is doing what is known by external beveling. And this external beveling means that the outer table is longer than the inner table. And we intentionally do that in the craniotomy flap all around the decompression craniotomy. And this was accompanied by a large subgallial dissection. We dissected the subgallial space for 5 to 7 centimeters around the skin flap. And this will give the chance for this bone to stay there without making more compression over the brain. And later on, when the tension is decreased, this flap will coming back again, avoid to sink down because of this bevel done. And after that, we fix it loosely with the vicryl sutures, and we are putting the drain under the temporalis muscle. And we are leaving the drain for we have a longer duration because sometimes we have more seroma formation. And the patient care, of course, as we know, on the other side of the head, and we don't apply any grip bandage. We investigated 30 cases of acute subdural hematoma presented to our neurotrauma unit in Cairo University, and we did them post-operative CT after doing this technique, and we found that the cortical surface in relation to the skull bone was in most cases not outside the outer table, which means that the space that we created with the subgallial dissection can accommodate for both without compression effect done by the bone flap that we left in the same operation. And this is one case for presentation that we can have here, like what you see with the midline shift, and this is the hematoma subdural, and this is the second day post-operative. The bone flap is here. As you can see here, the brain is just maybe in the inner or in the diploid layer, and the bone flap slightly elevated, but the midline shift was improved. So regarding doing another surgery to reposition the bone, we can do it with this technique to avoid this surgery. About 68%, 19 patients from the 30, had their post-operative CT with improvement of the midline shift with the cortical surface related to the inner table or the diploid, while 3 patients show no improvement in the midline shift, and we have 8 patients died before doing the CT post-operative. Although we have a mortality rate about 66%, but we revised the literature and we find a wide range of mortality in cases of traumatic acute subdural hematomas, ranging from 40% or 35% up to 80%. And our explanation is related that there are many other factors that affect the outcome than the pure decompression. Because as we said earlier about the pre-hospital management is very important. The time from trauma to surgery is very important, and the associated general condition is very important. So we consider our technique is effective regarding not to do another surgery or to keep the bone in the same operation, but of course, the outcome of subdural hematoma is multifactorial, so it depends on other factors. The duration of our surgery with an average of 3 hours, we have 3 cases of wound infection. 2 of them responded to antibiotic course, but 1 of them required debridement. I put this picture this was not in our study, but I put it to make the young neurosurgeons think about the design of a skin flap, because the base of the skin flap is very important and it has to be more wider than the length of the skin flap. Otherwise, we may have this picture with the skin ischemia and sloughing, and later on we have to consult one of the plastic surgeons to do a rotational flap for that. So it is very important to keep in mind that this length of the skin flap should be narrower than the base of the flap itself for the vascularity. So our technique allowed patients to achieve lowered intracranial pressure, proved by improvement of the midline shift in 19 cases in post-operative CT. And this was interestingly enough to avoid another surgery to replace the previously removed bone flap in classic decompressive hemicraniectomy, comparable to what was done by Professor Lepcherian, proposed that adding cisternostomy as a step in decompressive craniotomy to avoid a second surgery. And as we mentioned before, cisternostomy will need a learning curve that it may take time. Plus, when I was in Peshawar in the last year in the iCrane meeting, I met some of the neurosurgeons there in Lahore Hospital, the Neurotrauma. They are considering to put an external cisternal drain, which can give the same idea of cisternostomy, and it can be applied actually. So the practicability of the technique is more important than the effect of the technique. So they were putting like a drain inside the cistern. Whatever the cistern name, they are putting it inside to drain outside the CSF, having the same effect of cisternostomy. And they are following their cases, and interestingly, they have the same results like cisternostomy. So to take home message, hinge craniotomy may be a safe and effective alternative for cisternostomy in traumatic brain injury that require decompression to avoid second surgery, especially in centers lacking cisternostomy experience. Although gaining cisternostomy experience and other CSF diversion may help other indication, but future prospective studies and larger number are required. And for those who are interested in neurotrauma, the virtual conference, the iCrane 2020, will be held in the beginning of December. And these are the links, so you can do a free registration to attend a 2-day neurotrauma lectures if you want. Thank you.
Thank you, Dr. Ahmed, for this nice presentation. And for the sake of the time, we could postpone the questions until the end of the webinar, please.
ليه بس ليه كده ليه؟ احسن ننسى الأسئلة لأنه قال كتير قوي لازم يعني الراجل
Dr. Khan is here and he has a commitment as you like. So Dr. Nasser.
I think we can take one question from Professor Osama El-Ghandour, and then we proceed to our next presentation.
Thank you very much.
Let me first check if Professor Tariq Khan, are you already joining us?
Yes.
Thank you. Okay. Go ahead, Professor Osama, please.
Thank you very much indeed, Professor Ahmed. Your work is very good, and I just wonder for a few things. Number one, the problem is not just taking the bone. I think to make durotomy, duro incision, because if you take the bone, leaving the dura intact, you wouldn't have done anything. So the decompression should include widely open dura. This is number one. Number two, 10 years ago, I know that our Indian colleagues, they're doing cisternostomy or just going to the base of the skull and absorbing and sucking all CSF, and they claim that they have a good prognosis. I didn't see their cases, but this wasn't very rarely at that time very acceptable, but it seems it's becoming up again now. The other thing is that when you implant the bone flap in the tummy, in the abdomen, well, how long do you keep it till you have this regrowth of the bone? I mean, the effect for decompression craniotomy, not more than a couple of weeks or 3 weeks. I mean, if you keep that, it will be no effect of decompression craniotomy if your patient is not going to improve. In addition, you should put your patient on a ventilator as well to help decompression negative intracranial pressure. But the main point is, what are the indications of decompression apart from just continue? I mean, if you have a patient, no hematomas, just diffuse edema, and his Glasgow coma 3 or 4, would you decompress? And which side would you decompress, right or left? There is no shift. Thank you.
Okay, thank you, Professor Osama, for these questions. Regarding the first one, we actually do duroplasty. We are using the pericranial flap over the decompression bone to make this dural opening more wide, to gain a space for the brain itself. And so we are doing that. I agree with you that we have to do a decompression. Otherwise, how can we evacuate the hematoma? We should evacuate the hematoma and make more space by this duroplasty. And regarding the abdominal pocket, during the days that we were doing that, actually we maybe about 5 or 6 years, we don't use to do abdominal pocket storing for the bone. And I agree with you that as soon as we can replace the bone again to its place. It may take maybe less than 1 month. If the patient condition, general condition allows us to put it again, we can do it. But in some cases, as you know, either the cases die before or it become a vegetative. So we will wait till improvement or to feel that there is a value of returning back the bone. So this may take some months. And during this time, we noticed that the bone thickness is increasing and the size is shrinking. And regarding the time of, what is the last question, please? It was about the timing for decompression.
Well, not the timing, but the indication. If you have a patient with no shift, which side would you decompress? Or you decompress both sides, or one side? And Glasgow coma, very bad. From 4 or 3, would you decompress him or leave him?
Actually, in these cases, if we are going to do decompression, we will do bifrontal decompression, because there is no definite midline shift from one side to another. If there is from one side to another, so it will be associated with, of course, subdural hematoma. But if it is only brain edema and it is evident with increased pressure and low Glasgow scale, and so we can do bifrontal decompression. And these cases, Professor Lepchorian said that it is one of the indications of cysternostomy. The cases with no definite mass effect, but there is increased pressure and low Glasgow coma scale. In these cases, he is doing them cysternostomy. But since cysternostomy will need a learning curve, we may prefer to do bifrontal decompression for these cases.
Thank you. Thank you very much, Ahmed. I think for the sake of time, we have to proceed forward. Let me now introduce my friend and my brother, Professor Tariq Khan. Actually, we were together in Cambridge University in September 2017, sharing in an international consensus about the role of decompressive craniectomy in the management of traumatic brain injury. Let's now listen to the chairman of the Neurotraumatology Committee in the World Federation of Neurosurgical Societies. Actually, neurotrauma is a global neurosurgical problem, and it's very important to focus on the situation of this subspecialty, especially in developing countries and in Africa. Let us listen to Professor
Tariq Khan. He is going to speak about the management of neurotrauma in low and middle developing countries. Yes, welcome, Professor.
Hello, everyone. Thank you very much, Professor Nasser. Thank you for inviting me to this very important meeting. So I'm going to talk about somewhat about guidelines and how we should try and manage neurotrauma in lower and middle income countries. A very good talk by Professor Al-Fiqhi regarding decompressive craniectomies, which I'll talk a little later on. So guidelines are important in setting the minimal standards of care right from the accident site. And we must agree on minimal standards of care, core guidelines, and develop a system of care which grows as trained personnel and resources become available. For that, we cannot pick up the guidelines from Brain Trauma Foundation or from the American guidelines or Australian guidelines. We have to, every country, especially in the lower and middle income countries, there's a lot of problems. So we need to look at the local data, the transport difficulties, the resources, and what protocols can we use, whether we have ICP monitoring or whether we have ventilation or not. And interestingly, we developed guidelines for Pakistan many years ago, but they never took off. So, it is a very difficult thing, and I'm not sure whether in Egypt or in other lower and middle income countries, there are any set guidelines or not. We all know that, and this is from Key Parts publication, that 74% of surgeries for traumatic brain injury are needed in lower and middle income countries. These are not the surgeries done. These are the surgeries which are required. And also we know that 89% of surgeries for traumatic spine injuries occur in lower and middle income countries. So to look at the guidelines, we have to take a holistic approach right from prevention to rehabilitation. I think both the first one, prevention and rehabilitation, are the parts which are sorely missing in lower and middle income countries. And we did a survey some time back, Asian Australasian Society of Neurosurgeons, with our hospital and 3 hospitals from 4 hospitals from other places, from Indonesia and from India. Sorry, something has happened. My screen has frozen for some reason. Let me. Okay. So we looked at the helmet and seatbelt use in that survey, and we found that only 7% of people are wearing helmets and a very small number of people are wearing seatbelts. And we have this concept that one helmet protects all. So one person is wearing the helmet and the rest are just, and we try and make into the Guinness Book of Records to see how many people we can sit on a motorbike. I think, yeah. So a very important thing, they said that prevention is better than cure. And we started this theme many, many years ago when I came to Pakistan. And we were very successful in trying to prevent aerial firing at least, and trying to make people abide by rules. And we did many seminars and walks for that. And recently, the Neurotrauma Committee of the World Federation joined hands with Think First International Injury Prevention Foundation. And we did our first public awareness seminar in the ICANN 2019 in Peshawar last year. And we have been trying to educate young children in school also, and part of the programs in some of the bachelor programs, they go to these schools to train the children on brain trauma prevention. Then we looked at, in this survey, we looked at who provided the emergency treatment at the scene of injury. And we saw that majority was the pedestrian, the lay person, the shopkeeper at the site of the accident who provided the basic first aid. So again, that was something which was very important, because we all know, and everybody's talking about that, the initial few hours are very, very important. And then, so people started working on the shopkeepers and started training them in emergency treatment, especially in Jaipur in India. Our friends started working on that there. We looked at if a nurse or doctor accompanied the patient, and we found that the majority of the ambulances, there was no paramedic available, there was no doctor available. In fact, there was no oxygen or suction facilities in the ambulances which were transferring the patients really into the hospitals. And we all know that 50% who die from TBI do so within the first 2 hours of injury, and 40% of pre-hospital deaths are potentially preventable. And if we look at this, we know that there were more trauma deaths, pre-hospital deaths in the lower and middle income countries compared to the higher income countries in the first 1 hour. We also know that it takes a very long time for patients to travel from long distances to hospital. And we found in this survey that there was a big gap from the time of the accident to the time of arrival and then time to surgery. And we know that treatment is geared towards prevention of secondary trauma and rehabilitation, and secondary injuries like hypoxia, hypotension, edema, raised ICP lead to increased mortality. And longer the delay, greater the mortality. So it's very imperative that we need to train our paramedics, develop our ambulance services in the lower and middle income countries so that they can go to the site of accident and take up the patients and bring them in a proper fashion on the spine boards with oxygen, suction, collars, everything. These are all very important. Then the in-hospital management is guided by Glasgow Coma Scale monitoring, CT scan, ICP monitoring, pupillary response. And the goal is supportive treatment and prevention of secondary damage. The Brain Trauma Foundation guidelines, we all know general maneuvers, and then we know the first line therapy with CSF drainage, hypocapnia, mannitol, 3% saline. And then the second tier in which high dose barbiturates, hyperventilation, and decompressive cranectomy. Excuse me. So there's level 2A evidence that bifrontal decompressive craniotomy has been shown to reduce ICP, but not the US outcome at 6 months. And important that a large frontotemporal parietal decompression, as was suggested, is important to improve neurological outcome. We know that data from ICP monitoring reduces hospital stay. ICP should be monitored in all salvable patients. ICP monitoring is indicated in severe TBI with normal CT, but having 2 or more features on admission, age greater than 40, unilateral bilateral motor poisoning, or systolic blood pressure less than 90. So we know that majority of the severe traumatic brain injuries are managed without ICP monitoring. There's no recent literature to guide management in non-monitored patients. Large part of literature comes from well-equipped, larger centers in higher income countries. No resource-based guidelines in lower and middle income countries to guide surgical TBI management. So we developed a small committee which looked at to develop stratified guidelines. And this was position paper in the Journal of Neuroscience in Rural Practice, recommendation of the Colombian Consensus Committee, which was done. And this is a very good paper. I think you need to read that beyond one option for treatment of traumatic brain injuries, because looking at the pre-hospital emergency department and intensive care. And we wrote a paper on that paradigm shift from standard-driven protocols to resource-driven guidelines for neurotrauma management in low and middle income countries. So in our countries, in the lower and middle income countries, we need to look at our resources and then develop guidelines according to these resources. And that is why we asked them to develop the stratified guidelines for our countries. You know this very important paper by Randy Chestnut, and they did the best trip trial. And this found no evidence of outcome difference between monitored and non-monitored patients. And this paper took a lot of flack from developed countries and neurosurgeons in developed countries. This trial compared ICP monitored patients versus non-monitored by clinical examination and imaging, called the ICE protocol. So then this paper was written, consensus-based management protocol for the treatment of traumatic brain injury based on imaging, clinical examination for use when intracranial pressure is not employed, which is most of the countries where we live. So this is not a substitute, but a supplement in efforts to provide for the vacuum left by the absence of evidence-based guidelines. And they involved 43 intensivists and neurosurgeons. So how we do it? So we would either do a decompressive cranectomy on admission. We would do either ICP monitoring through intraventricular catheter, if possible. And if not, then we use the Crevice protocol. So the indications which we have for the decompressive cranectomy is the CT scan findings of diffuse brain edema, with or without brain contusions and subdural hematoma, the effacement of basal systems and ventricles, midline shift, GCS of 9 to 12, or drop of 2 degrees from previous. And we look at the age because we know that there is 75% of mortality over 70 years of age. And if you're doing ICP monitoring, then refractory high ICP for more than 22. The management protocol is, if we use the Crevice protocol, We use the Marshall score on CT brain. We do interval CT scans. We do clinical score, DCS neuro, looking at the neurosurgical worsening, the pupillary response, and we have a 4-tiered management response. So I'm sure our young neurosurgeons know about the Marshall grading, which depends on the systems, the midline shift, and the mass lesions. And we look at either one major or two minor criteria. And these are the major and minor criteria which are available here. And neuro worsening is decrease in the motor GCS of 1 or more points, new loss of pupil activity, interval development of pupil asymmetry, mydriasis, new focal motor deficit, herniation syndromes. So how do we do the imaging? Initial and repeat at around 12 hours. If initial was done at less than 4 hours, then we repeated 24 hours, 48 hours, and PRN. So what we do is that every 24 hours, we stop the sedation. We ventilate all the patients, sedate, paralyze, and ventilate all the patients. And we wake up the patient every 24 hours. We check their Glasgow coma score, look at the pupil response, repeat the CT scan, and then see if they are improving or getting worse. So the first tier is giving hypertonic saline or mannitol or maintaining normothermia. If the patient is worsening, then we increase the ventilation for some time. We give hypertonic saline 3% by continuous infusion and increase the sedation. Tier 3, if patient is still getting worse, then we would do decompressive craniectomy, mostly. We don't have the thing to give IV barbiturates or hypothermia really. And tier 4 are the untested protocols, which we don't use, but these are part of the Crevice protocol. So escalation of therapy is considered if there's neuro worsening, if there's no improvement or worsening on follow-up CT imaging, if there's no acceptable response to initial therapy. And this is a module for that. And then important thing is that when to stop the ventilation. So we use the Marshall score, the pupil response and the motor response. And if you can see in the first 24 hours, most is red, they do not take up the ventilator. In the following 48 hours, then there are more people can be taken off the ventilator, and so is that. And I suggest to all of you that we should develop a study on this thing to compare patients with ICP monitoring and patients without ICP monitoring using the Crevice protocol. If anybody is interested, they can write to me. Now, rehabilitation, again, one of the most important parts often neglected in developing countries. We know that it's a multidisciplinary approach. And what we have started doing is that we have involved the family members to help, to train them, and when they take them home so that they can take care of the catheter or take care of the tracheostomy or take care of the bed sores and everything. I think it's very important, and it's a very good paper written from Aga Khan on the role of family members in that. And as you can see, that in that survey which we did, we found that majority of the patients are going home to their family because there are no rehabilitation services available in the lower and middle income countries. So in 2019, November, we developed the Peshawar recommendations, which were the comprehensive policy recommendations for head and spinal injury care in LMIC. It was by Key Parks Group in Harvard and the Northwest School of Medicine. And these are policy recommendations. These are not recommendations for neurosurgeons. And what we did was that if you know the National Surgical Obstetric and Anesthetic Plan, so in Pakistan, we were able to piggyback these recommendations onto the National Surgical Obstetric and Anesthetic Plan. The new thing has come up. It had many names before, but now it's called global neurosurgery. And it's, in addition to doing neurosurgery better, how to better deliver neurosurgical care to all who need it. And this was from the comprehensive recommendations was that we should have 80% of the world should have access to essential neurosurgical care by 2030. The plan is to take it for the universal health coverage. And that 90% of LMICs with national neurotrauma plan placed by 2021. I don't know if we can do that. And this was the timeline given that we are going to be presenting in Bogota in August, whether virtually or physically, I'm not sure yet. So you know that the Global Neurosurgery Committee was formed by WFNS, and that was to achieve universal access to neurosurgical care and to align and coordinate all global neurosurgery activities and to engage with everybody and to co-educate for investing in surgical care for all within universal health coverage. And this is what I'm talking about, the National Vision for Surgical Care 2025. Now, as we know that we have very few neurosurgeons, and somebody pointed out less than 15 in Kenya. In Australia, you know, still today they practice by the general surgeons would operate on neurotrauma. Now, because of all the facilities available, we can, with support of teleradiology, Skype, we may be able to help general surgeons in far-flung areas if it is required. I know it's a controversial subject, but people are doing it in Australia and people are doing it in Northern Ireland and Belfast, where I trained, and they've been doing it for many years. So thank you very much. This is my...
Thank you, Professor. Thank you, Professor Khan, for this nice talk, raising the issues of these international guidelines for management of these cases. I think we could shift to the second topic and make the questions after the two topics. Is it okay, Dr. Khan?
Yeah, let me get rid of...
Okay, now we shift to the second topic from Dr. Khan about the cranial missile injuries. Yes, welcome, please.
Yeah.
Are you ready, Dr. Khan?
Yeah.
Until I see, okay.
Okay, this is my second topic, civilian cranial missile injuries. This is something which happens a lot or used to happen a lot in Pakistan, still happening in Afghanistan, our next door neighbors. So we see many of these patients coming in. We know that they carry a very high morbidity and mortality. And there are different types. You have a low velocity injury, you have high velocity injuries, and you have blast injuries, and then others. So the low velocity are by handguns, which have rifling, and the muzzle velocity is 700 to 1400 feet per second. In the high velocity, the muzzle velocity is very high, 2200 feet per second, with a very high kinetic energy. And then it has a yawing effect, which can cause a cavitation effect. So if you look at the bullet, it is it's going straight, and then it tumbles and develops a large cavity and gets back to straighten. And so it can cause 25 times of the damage of the bullet. So the longer it has to travel, the more damage it will do with the high velocity bullet. So the incidence depends. Mostly majority are in the frontal, temporal, and parietal regions, and posterior fossa and base of skull 0 to 5%. And you would likely not see the ones with the posterior fossa and base of skull because they usually die at that time. So the severity of injury depends on the nature of the projectile and the point of entry and angle. So low velocity will have a low kinetic energy and minimal shock waves, and it would enter into the weak points like the temporal region or the supraorbital region. And the high velocity will cause high kinetic injury and shock waves. You can see this you can imagine what can happen because of a high velocity bullet injury. And blast waves, blast injuries, shock waves cause temporary vacuum effect, stretching, deformation leading to further effect, and the penetrating missiles. So the nearer you are to the blast, the more damage you can get. The further you get, the less chances. So when you're near, you get burnt also, and you get the overpressure waves and the impact and everything. And the further you get, it becomes less. Management is basically as for everything, A, B, C, D, E. Plain X-rays can be very helpful. CT brain with bony windows and 3D imaging, and CT angiogram where there's suspicion of vascular injury. Mannitol of 3% saline. In some cases, because of the high velocity injury, you can already have a decompression effect with a large defect in the skull with the outgoing bullet, so you may not need to give them any mannitol or saline. 3%. So craniotomy is important to remove the devitalized tissue, removal of accessible bone and bullet fragments. So the important thing is that we remove the accessible fragments and the bony fragments, and we do not go digging for the bullet, because that you're going to cause more harm than help. And copious irrigation with saline, that is the most important thing to do, is that you need to keep on washing so that all the debris can come out as much as possible. And of course, hemostasis, and then good dural closure. And we use obviously pericranium, Gallia fasciolata. If you have the luxury, you can use artificial dura and adequate scalp closure. So high velocity, high incidence of infection, and in pre-antibiotic era in military injuries, more than 60% deaths from that, from infection, and now it's much less also in civil. So Staph aureus is the most common organism, so cephalosporin with metronidazole, and of course anti-tetanus is the one to be given. So this NCBI also says the same thing. Seizures are more common than close traumatic brain injuries. Whether to give prophylactic treatment or not, it is suggested that one should give, because 30 to 50% of patients can get seizures in the first 7 days. And if you do not give prophylactic anticonvulsants and they have a seizure, and if the patient is not well controlled, intubated, sedated, the patient can get worse. Patient can deteriorate because of aspiration, etc. So it is better to give them anticonvulsant therapies. I normally give them for at least 6 months to these patients. And of course, post-operative care is very important as every patient. Rehab, again, as I said, is something which is very important. I'll just give you a little short study on patients which we get from Pakistan and Afghanistan. We grow up with guns. Everybody, kids love to handle guns, and parents, unfortunately, love to give the guns to the children. And this is how we celebrate weddings. And this is how we settle disputes. So very sad, unfortunately. So the study was to determine the prognostic indicators of early in-hospital mortality in civilian gunshot wounds to the head. It was a retrospective analysis for 4 years. We have now more data, but we have not put it online yet. So there were 96 patients with data available, and looked at the demographics, arrival GCS, police status, Rotterdam score, CT characteristics, and GCS at discharge and mortality. So mean age was young patients, and the median arrival was GCS was 7. So 52% had less than GCS 8. And CT findings were basically all, bone pieces, fragments, bullet fragments, etc. And 55% had a high CT score. Mortality was 3%. If we look at the blast injuries, we had some patients, about 18 patients, CT score, etc. And again, the mortality was this. This is the Rotterdam CT score if somebody has not looked at it. It includes 4 independent score elements: degree of basal cistern compression, degree of midline shift, etc. If there are any contusions, epidural hematomas, and intraventricular or subarachnoid blood. So these are some of the patients with the bullet injuries. And this is obviously a blast injury. So the conclusions were that civilian gunshot wound blasts are seen in young adult males, frequently as a result of assaults. 1/3 of patients are received in very low GCS and poor pupillary status. Arrival GCS and pupillary status are strong predictors of mortality. And again, I would like to stress the importance of prevention for neurotrauma, which can save a lot of lives. And okay. And thank you, Professor El-Fiqi, for telling them everybody about the virtual ICRAN, which is going to happen next month. And in that, we have for young neurosurgeons, we have 8 slots, so they can put in a case presentation. I think the emails and all are there. If you go on the WFS website, it's there also, and in the WFS newsletter also. So we will pick up the 8 young neurosurgeons, and they will also present in the ICRAN 2020. So we look forward to all of you to be joining us that. Thank you very much.
Thank you, Dr. Khan, for this nice presentation, for joining us and sharing your experience. Yes, we may open for discussion. We have 15 minutes for discussion.
Yes. Can I?
Yes, please. Welcome.
Yes. I will start from the second to Professor Khan. Well, we are not too far from you. In our Upper Egyptian place, the celebration wedding, they're using the firearm and Kalashnikovs and all types of missiles can happen as well.
And the Dr. Osama from there, right? That's right?
Yes.
I think he's carrying now a Kalashnikov or what?
Yes, I've got one to protect myself, you see.
Yeah.
Sometimes you see a bullet stagnant in the skull or the brain inside and not doing anything. We just leave it. Some of them, they do move, and then if they move near the foramen magnum or cerebellum, we take it out. But if they are not moving, we observe them. We don't do anything. I just wanted to know your opinion about that. About the first paper, I've seen you doing decompression for cases. If I were you, I would go conservative. I mean, Glasgow coma 9 or 10 or even 8. I wouldn't do anything. Normally, they improve unless I'm doing, seeing progression of a hematoma or deterioration clinically or doing intracranial pressure monitoring. But if I were you, I wouldn't really do this. Why you are so aggressive about treating these cases of high-grade Glasgow coma scale? Thank you.
Thank you very much. Okay, first of all, yes, I agree with you. These bullets can sometimes move, and they can be then alarming for the patients also and everybody. If they come near the vital structures or they block the ventricles or things like that, yes, it will be an idea to remove the bullet if possible, definitely. Coming to the decompressive craniotomies, to be very honest, me personally, now I've become very, very conservative in doing decompressive craniotomies from what I remember, what I used to do maybe 20 years back. I agree with you that one should be not as aggressive. This is a protocol which we have recently started looking at the ones done in South America. But we are now trying to do more and more ICP monitoring. intraventricular catheter ICP monitoring. And we found that if we do the ICP monitoring and release little CSF when the ICP goes up, the number of decompressive cranectomies have become much less. We have not tried, as Professor Al-Fiqi pointed out, doing cysternostomies as IPE, and now there are many people who are looking at that. And that is why we have given a chance to Ayub Chirian to talk about his cysternostomies in the ICRAN, virtual ICRAN, so that we can develop a little good discussion on that. And I agree with you, yes, one should be a little more concerned.
Thank you,
Thank
Professor
you very much indeed.
Osama Al-Ghanem, Professor of Neurosurgery and former Dean of Faculty of Medicine at Azhar University and Honorary President of the Egyptian Society of Neurological Surgeons.
May I have a question, Dr. Khan? Dr. Khan?
Yes.
Dr. Khan?
Yes, please. I'm here.
Yes. I'm just asking about, do you have a time window for doing the decompressive craniotomy?
Sorry?
Do you have a time window for the decompressive craniotomy? How many hours you could do it successfully and with a good prognosis?
Yes, you know, long time back when I was training in Belfast, our consultant used to say that if you wait too long, you're running after your tail. Because once you have the patient has corned, if the pupil gets dilated and you're still waiting, you are going to really lose that patient. So if you're not doing the ICP monitoring, you have to really look at the GCS very carefully and ensure that if there's a drop of GCS, you should immediately go for decompressive craniotomy. In patients who have come with a low GCS, I think one shouldn't wait at all and again do it as soon as possible. So to say exactly how much time on which patient is very difficult, but you have to take it from case to case. So you have to do it sooner than later.
Thanks you. Thank you.
Abdul Hafiz, I can see in the panel question to Dr. Abdul Hafiz.
Actually, it's a question for both speakers.
Let me say the question first. Would you like to how many cases you experience intraoperative complications with anterior approach, and how many cases return with construct failure with the anterior approach? And there is another question in the panel for you too. Is there any limitation if the patient has scoliosis?
For the first question, actually, as I mentioned, there is a list of complications. And we have various complications like superficial infection, like neurological deterioration, transient neurological deterioration. Like, of course, the patient is I put underwater seal after my surgery as regard if I am doing parietal pleura opening. But the most important point, how many failures of the instrumentation, and how much I have to, how many I have to revise, and how many I have to do concomitant posterior instrumentation. This is actually the most relevant questions. As regards to the amount of failures, it's about 8 cases in about 700 cases that has been done. As regards to concomitant or adding posterior instrument system removal, this is important too. I have to remove the system in about 6 cases, and this is the early cases where I was using 2-point fixation devices, not 4-point fixation devices. I mean, this is about 28 years ago. And but by using recent tools like bullet screws with point fixation systems, I don't remove any system. I am not in need to do. No system fractures had ever even. But I have to do posterior concomitant posterior fixation add it to the anterior one in 12 cases. For the second question about the incidence of scoliosis, how to treat and what should I do? I mean, this is thoracolumbar trauma. Traumatic cases is fresh cases. It's quite different from deformity cases. Either this deformity is due to scoliosis itself, whatever it's induced by previous trauma, or so you consider scoliotic cases as another category. But if the scoliosis or the deformity is produced by the trauma itself, I correct it during my surgery. I can regain sagittal and coronal balance by fashioning of the spacer and by instrumentation, but I may need, if there is a gross deformity and the failure of the posterior ligamentous complex, I will add posterior instrumentation in addition to anterior one. That's to say 360 instrumentation.
Thank you. I think Ahmed raising his hand. He wants to ask Professor Tariq.
Yes, please, if possible.
Yeah.
Thank you for a nice lecture about the missile injury. I have a question. If you have an experience about a bullet which can move inside the track, as you said, the bullet, when it traverses the brain, it causes a cavitation. So this track is wider, and sometimes, and we see it in one case, that the bullet was moving, and this movement was for a girl about 17 years from North Sinai, and this bullet was, after stabilization of the condition and the hematoma resolved, it start to move and start to do more weakness on the other side of the body. And it was deep enough that we have to remove it, and we have to use neuronavigation to reach it. So do you have any experience of cases like this, or what you are dealing with them, like what we did, or what else? Thank you.
Thank you. Yes. Well, I've seen these bullets, mainly Kalashnikov bullets. So we used to have a lot of patients who would come in not knowing what hit them. And these were spent bullets which would go up into the sky and come back at 32 feet per second and penetrate and do that. Or these were the stray bullets which would go in trajectory and hit them. And the patient would be quite well for quite some time. And then these bullets start sinking down towards the base of the skull. But frankly speaking, in my personal experience, I have not seen anybody deteriorating in a fashion that I had to then operate on that. But of course, yes, they do move, and they can cause increasing damage, and then they have to be removed, and that would require a lot of skill because they would be in areas, and if you have the neuronavigation available, I think that is the best way to do it. But you can even use ultrasound for that purpose to try and do that.
Okay, thank you.
Omar? Yes?
Do you have any other questions?
In the chat.
There's a question for Ahmed, I can see, I think.
Nothing in the chat. And the Q&A.
Question for Ahmed, I can see now. What is your comment on performing titanium cranioplasty after a long decompression? And I think Professor Tariq Khan, we can have the same question for Professor Tariq. I will say it again. What is your comment on performing titanium cranioplasty after a long decompression? Let us first, Professor Tariq, please go ahead.
So, there were two very interesting meetings. The one we were in Cambridge regarding the role of consensus on decompressive craniectomies. And they had taken up the cranioplasty one a bit. But then in Naples, in the ICRAN in Naples in 2018, there was a consensus meeting on cranioplasty. And I must tell everybody that it is not just for cosmetics or not just for prevention of injury to the brain that you need cranioplasty. It is important to redevelop the normal physical structures of the brain and the normal dynamics of the brain to do a cranioplasty. So it's not just that. Obviously, the best thing is to use the own bone which has been removed. Of course, we know that if that bone is kept in subcutaneous pouch, there are chances of increased resorption of bone. So it is recommended that it should be put back in earlier compared to if you are going to do a different type of cranioplasty. Titanium cranioplasty is much easier for availability in lower and middle income countries. But one has to be very careful that it is screwed in properly and that there are no sharp edges, because it can very easily erode the skin at a later time. And of course, there are many others, peak and hydroxyapatite. And interestingly, back in the 80s, there was a lot of blast injuries and firearm injuries in those days in Belfast. And we used to use titanium. And in those days, the titanium, they would make fitted for that particular patient. So for me, I feel titanium, if own bone is not available, we have a bone bank, so we are lucky we can put them in a bone bank. But for reasons it's not available, titanium is much cheaper available. Also, you can use hydroxyapatite. You can develop it in a nice fashion, custom built, and do it. And do it sooner than later. Being in a vegetative state, if you can convince the relatives, because they will not be convinced to do it, I think it might sometimes even help in achieving it.
Okay, thank you, Professor Tariq. Ahmed, are you using this titanium mesh in your cases?
Yeah, actually, in the last maybe 3 to 4 years, we are not using titanium mesh because we have a lot of problems that happen with this titanium mesh, especially in areas where the skull defect is having a contour. So it may lead to piercing the skin, and the screws may go through the skin. So we are more familiar with using acrylic bone cement. So we can custom the bone cement by our hands. We can formulate the size according to the defect size, but it will need some experience to do it, especially in the areas of supraorbital region and the orbit itself, because it is curved and it needs some contouring. So we have to do it with the other side. We do bifrontal craniotomy incision to expose both sides to formulate this acrylic. And more recently, we start to use a 3D custom-made flap, which is formed with the new material according to the defect itself. But of course, it may be expensive, so we're still using bone cement for these cases. Yes.
Okay, Abdul Hafiz, you want to say your experience?
Actually, I come over a few cases of bullet injuries, and I find the navigation, the use of navigation is very beneficial. But the most important, we know that navigation is not real time. So delay your images till the morning of surgery, and be ready also with an image amplifier. It is in just a few cases that you may need to remove that firearm bullet also. But I have a question to Dr. Khan about the difference in the outcome of your craniotomy between the cases. I mean, I find that when the patient is severe head injury, the morbidity and the mortality is extremely high compared with that cases which is around 8 to 10 or 12. Do you have this experience, and you can give us some, both speakers can give us some prognostic criteria for patient selection?
Yes, so as I said, I don't perform decompressive craniotomies anymore on GCS below 7. I don't perform decompressive craniotomies with both fixed pupils. I do not, I try and avoid doing decompressive craniotomies over age of 70. I was asked a question that why would you be so aggressive in doing a higher Glasgow coma score? Because if they deteriorate, you have missed your chance. So one should look at if somebody has got a GCS 12 even, and if it's gone down by 2 levels, I think it is best to do a decompressive cranectomy. If you are having ICP monitoring, that, of course, may help you in making a decision. But for people who are not having ICP monitoring, I think the GCS score is very important. I think the pupils are very important. But then what happens is that if you ventilate a patient, paralyze, sedate, and ventilate a patient, then you are left with only the CT scan and the pupillary reaction. So you need to, that is why the CREVICE protocol has come into being, that you can look at the pupils, you repeat the scan, you wake up the patient, stop the sedation every 24 hours, and you see that the patient is getting worse or getting better. So very easy with ICP monitoring, very practical, and a lot of it has to do with your own personal experience as your age goes on, as the number of cases you have done, you will find that one tends to slowly become more conservative rather than wanting to do more and more decompressive.
Dr. Ahmed, you have a comment about that too?
Yes, I agree with Professor Khan about the Glasgow Coma scale. If it is below 8, we can give the patient a chance, and we can avoid doing this relatively large surgery in old age. But I'll add one indication, which is witnessed deterioration, which when the patient is coming with a conscious level and we see that the patient is deteriorating within maybe 1 hour or less. So this will be of the good responder patient. So we have to give him the chance rapidly. This is my only comment about more indications, yes.
Thank you.
It's a very important discussion, and I'm much concerned about our continent, the African continent, and the developing countries. As you said in your presentation, that we lack the number of neurosurgeons. There are maybe 11 countries without a single neurosurgeon in Africa, and many countries with 2 or 3 neurosurgeons. And I'm happy to know that the World Federation, through Professor Tariq Khan, is putting a plan, and they are concerned about the development of this subspecialty, especially in Africa and the developing countries. And I think that one of the most important issues which should be taken into consideration, that we have to educate non-neurosurgeons, like general surgeons and orthopedic surgeons, in order to know how to deal with neurotrauma patients, how to do the simple procedures which may be life-saving. And this will give the chance for the specialized neurosurgeons to allocate the time in order to do more complex neurosurgical procedures. And that is a priority which should be taken into consideration when dealing with this subspecialty in the African continent. I think by answering this question and by making this important discussion, it is time to close the webinar. At the end of this webinar, I would like to thank our distinguished speakers, Professor Tariq Khan, Professor Abdul Hafiz Shahab al-Din, Professor Ahmed El-Fiqi. It was a very successful webinar addressing one of the most important subspecialties, which is neurotrauma, especially in developing countries, which is actually a global neurosurgical problem. And I would like to make an announcement that next Friday at the same time from 2 to 4, our webinar number 25 will be about craniocervical junction surgery. We will have Atul Goel from India, and we will have Ali Abu Madawi from Egypt, and Ihab Isa from Cairo University as well. I would like to thank the moderator of this session, Professor Omar Youssef. Thanks to
you, Dr. Nasr. Thank you.
Pharma for organizing this webinar, and thanks to all attendees.
Thank you. Thank you for all.
Thank you very much indeed, everybody.
Thank you.
Thank you, Prof.
Much.
Osama. Thank you.
Thank you.
Thank you. Bye-bye.
Thank you very much.